You can use it. Well, I'm going to repeat a little bit of what I said last night, and what I want to introduce is a program that I've run for the last 6 years at Harvard, which is called Social Technology for Global Aging. It's a research program, and it is unusual in that it involves 6 of Harvard's schools: our engineering school, our medical school, School of Public Health, Graduate School of Design, the business school, and I think that's it. And it has a group of Harvard professors and then a substantial group of professors from other universities, most of whom are in China. It has a series of trainees, postdocs, students who both work as research assistants and go out and do their own projects. It has a substantial administrative staff, and it's, besides a steering committee, every 2 weeks it has an academic seminar, which is on Zoom and involves about between 50 and 60 people around the world, most of them in Boston or in Beijing and Shanghai. And it focuses on a particular approach to technology in medicine, which we're calling social technology. At the end, I'll have a specific statement that says what this is, but I'll tell you right now what it is. It's a interdisciplinary, cross-cultural approach in which from the very planning through the implementation to the evaluation of research projects, anthropologists, engineers, physicians, design people, and others, including public health experts, work together with no one particular field dominant, and many different kinds of projects that I'll try to illustrate in a bit. And we'll start on this with AI. And I mentioned this briefly, but this is one of 2 major projects we have in the AI field, and we're expanding them. One is with Professor Jill Bennett from the University of New South Wales in Australia. And this is the project I mentioned that uses AI and VR. It's a kind of reminiscential therapy in which you put pictures and movies and videos into the VR that come from a particular person, their social context and life, and have to do with when they were joyful or calm and relaxed. And as they progress with dementia and become more and more agitated, being able to return to these places in virtual space is amazing in terms of the way it melts agitation, anxiety, and allows people to be in a good state without being knocked out by antipsychotics or restrained in any way, whether mechanically or electronically. Another project that we have in this area uses AI for other aspects of the experience of people with problems relating to aging. And if you think about what aging involves, although the context is radically different culturally in China and the US, the problems are awfully similar. So one is isolation due to mobility problems, okay? Another one is the need for assistance in things like climbing stairs and the like. We have a project that brings together assistive technologies, AI, and the different disciplines that I have mentioned to do things like assist elderly people to be able to walk upstairs. So those of you who know the field of exoskeletons know that amazing developments have been done in that field. And one of the people who works with us, Connor Walsh, has developed astonishing exoskeletons that look like a thick pair of pants attached to a battery and a motor, and that when properly trained and deployed, a person who's had a stroke or has the fascinating gait of Parkinsonism, they can walk normally. And the issues then become rather interesting issues. Why do some people choose not to use these assistive devices? And indeed, on our Chinese side, almost all of elderly Chinese refuse to use these devices because they didn't really fit in with what their needs were. And that's where the anthropology comes in and the psychiatry or psychology comes into that. So the argument I made last night, I make again, is that in the area of caregiving, and I mean broadly in the area of caregiving, of course, we heard wonderful presentations just now before the break. In all those areas and others that I mentioned last night, AI should never replace caregivers. Okay? If you come away with anything from my talk, that's the fundamental basis of the talk, and we have a huge amount of evidence to support this. AI should not replace caregivers. Rather, what AI should do is augment, strengthen, elevate the work of human caregivers, and it can do that in many different ways. The great danger is that this is really not, that what I just mentioned, is not the interest of either the large technology companies or the startups that are happening all around us every single day. They're not interested in augmenting or enhancing. They're interested in substituting. And so this, for all of us, is going to be a very substantial problem because, as I mentioned last night, the horse has left the barn. It's already happening. AI offers useful possibilities for many kinds of healthcare interventions. In many of the elements of healthcare, both professional and family. So from diagnosis through treatment planning to actually implementation, AI can do many different kinds of things. AI can help measure the quality of care, and this is what I'm particularly interested in, because I can't, again, it's another point I would emphasize, I can't emphasize enough. We do not measure the quality of care. We do not measure the quality of care. We measure institutional efficiency and substitute it for the quality of care. Sometimes institutional efficiency contributes to the quality of care. Often, it's a problem for the quality of care. Excellent care may be equivalent to excellent efficiency, but excellent care may also suffer from an excess of efficiency. AI can contribute to integrative care, to care that brings together many elements from our world, not just professional care, not just family care, but all the technologies today that are being mobilized in the healthcare domain. AI may be able to identify aspects of the patient-doctor interaction in areas like, in my interest is in traditional Chinese medicine, that it can be used, transferred over to biomedicine to improve clinical communication in healthcare systems. And the reason I mentioned this last night, you remember, is that in China's, in a huge society like China, it's only biomedical physicians who are having a tremendous problem with trust amongst patients. Traditional Chinese medicine don't have that problem. So what is it in their relationship or in their slow care that prevents that from happening? There are ethical challenges of AI. There are very substantial, and these have been so widely reviewed, I'm not going to go into them, but there are very substantial issues with privacy, confidentiality, and security. So almost everything we associate with social media, the internet, is going to happen with AI. So AI is going to be hacked, okay? And the hacking of AI may take place without awareness of people who are using AI, and the consequences will be unfortunate. Criminal activity now is centering on AI. So you can be sure that just about any kind of scam you've seen in the health domain with other technologies is going to be advanced by AI. AI can capture your image, capture your voice, and make it sound to your patients like you're telling them to give them your bank account or other personal information that you would normally never ask for, but that crooks want to have. And I've talked about this, about the different ways that AI can measure quality. And what I'm particularly interested in is clinical judgment, how AI can help us with clinical judgment. And I think teaching about clinical judgment is central to medical education, medical students, and the training of residents. And I think we're going to see a real increase in attention to this with AI. But given the time that I have, I'm not going to go into this. I can come back to it in questions. And these are just some of the ways that AI can measure the quality of care. Now, the limitations of current AI models. I mentioned last night again that they're evaluated in the clinical domain and in almost every domain against multiple choice questions. But that's not the way we give care. We don't give care against multiple choice questions. We assess patients, come up with a treatment plan, give care in a setting of ordinary conversations. And AI has yet to master ordinary conversations, but it's getting there. As anyone who's worked with AI as a medical scribe knows, AI is a fabulous medical scribe. It can listen to your interactions with patients. It can filter out everything that doesn't have to do with the clinical work itself and come up with a tremendous summary for you, better than you can do, okay? And it also can give you the literature relevant to that. And connect you to the relevant, the important information. So, now, we got to acknowledge AI's risk. And in my field, in the mental health field, it has very particular kinds of risks that are troubling and need to be dealt with. One of which is it can actually not only hallucinate and confabulate itself, it can intensify hallucinations and delusions of others. And we have plenty of evidence for that. So much evidence that in my own mind, and this is probably a minority position in the mental health field, I don't believe that AI should be used with psychotic patients because the vulnerability is too great and the potential for disasters is very, very high. In the same way that I don't believe that AI should be actively involved with suicidal patients, because we have plenty of evidence that AI can relatively easily contribute to suicide today. And you're going to hear much more about this because the material is being collected now, and this will be in the media. But the inevitable future is that AI will be as integral to our lives as the internet is. And this is happening now. I use AI every single day, and my students use it every day. And it's going to be something we use maybe every hour. And it'll be just part of our lives. And we'll look back 10 years, well, I won't be here for that, but you will look back 10 years from now and say, what a silly discussion, because AI is everywhere and everything. And that's what AI is becoming. So our engagement with AI will shape not just care and ethics, but all human interactions will be shaped by AI. And we should be thinking about that. So this is not just in the health domain. This is in the legal domain, the criminal justice domain, the sales domain, the entertainment domain, the vacationing domain, every domain you can think of, including intimate relationships in the family. AI is going to be a strong part of that. And again, we should be thinking about how are we going to negotiate that and control it, et cetera. And here I want to emphasize something again I said last night, that care is not just the things you heard today. Care is also about control, okay? An important part of care is control. We don't like to talk about it, and we separate care from it, but just think about it. If you're a parent, half the things you're doing with little toddlers, but also in my experience with middle school, young adolescents, is control, okay? And control is important for an elderly person. You don't want, in North America, your country, Canada, and the United States, every year, 1/3 of people over 65 years of age have a fall, okay? Some of those falls are meaningless, just happens, someone gets up and they're right back. But a number of those falls lead to broken hips and other fractures and are often the inflection point of where people who were doing pretty well in their late 80s, early 90s, then slip into nursing homes and death. So AI is going to shape all of this, and it's going to shape our ethics. And I have an opportunity we had a wonderful presentation by Kerry earlier, and I have an opportunity to go to her institution, Stanford, and talk a little about this, that it's going to actually shape our ethics, the way that what our values are and how we think about values, okay? And again, it's important to recognize AI is nothing more than a pattern-recognizing set of algorithms, okay? Has no brain, has no limbic system, has no social context, isn't a person, okay? You're interacting with algorithms. And those algorithms, as they get better and better, are going to be limited by that fact that they are always operating at the cognitive level. But we don't just operate at the cognitive level. I mean, because we had such nice talks earlier, in each of those talks we had just before this, you could see the working of the unconscious. Okay? We don't talk about the unconscious enough in medicine. That's more or less unformulated experiences within us that play a large part of who we are. Why is it we do things when we know we don't want to do them, we shouldn't do them, but we end up doing them? Why do we have dreams like we are amazed at what appears in a dream? How about all that material that we can't reveal to others and can barely reveal to ourselves, okay? That's the unconscious at work. Medicine, I wrote a piece in the New England Journal about this. Medicine operates without attention to the unconscious, okay? AI is going to have nothing to do with the unconscious, can't operate with the unconscious, okay? This is going to be a huge part of the way that AI becomes part of our lives. So we need to understand what are its uses and misuses. And this is a good time, since we're still pretty early in it, to ask what are the comparative advantages of AI and what are the comparative disadvantages of AI. And I think that coming up with a list like that will be one of the contributions I'm sure that researchers will make. This is a more formal definition of what the social technology approach that I introduced earlier is about. And you can see how this would work with AI. That if you bring together not just physicians, not just electrical engineers and biomechanical experts, but if you bring together anthropologists, psychologists, you're going to have a much broader engagement with what AI can do that's useful and what AI can do that's not so useful. So for example, just think of the social science dimension of this. In the 1940s, the great Columbia University sociologist Robert Merton introduced one of the most powerful ideas that is central to everything we do in medicine, called the unanticipated consequence of purposive action. The unexpected consequences, okay? Almost every intervention we use has unanticipated consequences. Okay? Again, working with AI, we've got to ask that question now, systematically. When we use it, what are the unanticipated consequences? And Merton had a great phrase for this. Let me see if I can remember it. At 84 years of age, I can't come up with things the way I used to when I was the average age in the room here. But he called it the imperious immediacy of the present. The imperious immediacy of the present. That's so dominant is our present focus on the things that we're concerned about, like outpatient surgery, a psychotherapy session, an internal medicine meeting with someone with diabetes. So focused are we on the present that we simply don't think of alternatives that are going to happen. And that's what we need to do, and we need to do it with AI. Social technology is caught up in human values. And so what we're hoping that the social technology approach will do is to be one of the ways, I'm sure we'll have multiple ways, to humanize AI. AI constantly needs to be humanized, supervised, brought back to human sovereignty, human governance. We don't use the word sovereignty too much in medicine. We like to use other terms like autonomy. But in the real world, sovereignty is the key word. It means governance. Governance. Who has the power to govern? And this is a story relevant to racism. It's a story relevant to colonialism. But it's also a story relevant to AI. Where is governance going to lie when it comes to AI? And we've already been told by the developers at AI that they expect it to undergo cognitive leaps that will eventually allow it to have sovereignty. Okay? So we should prepare ourselves for what does that mean in the health domain? What will it mean in the health domain when we employ AI and really don't have control over it? We don't have control over it. Rather, it has control over us. That may sound far-fetched. Let me just tell you, that's going to be every day for us in another 5 years. This is going to be our reality 5 years from now. We're going to face every day the issue of who has governance in this particular situation vis-a-vis the use in medicine and healthcare. And actually by families of AI, because that's the other point I should make. This is not just happening in the medical aspect of the healthcare system. I spent much of my career showing that healthcare is not just about hospitals, about clinics, about pharmacies. Most of healthcare is in families. More than 3/4 of illness episodes are treated in families without ever getting to a doctor or a nurse. Okay? Huge number of decisions are made by families. AI is going to be crucial to that. And your patients are going to come in AI informed about what they would like you to do. And you're going to, or what they not only like you to do, what they expect you to do. And you're going to have to respond to that. We're going to have to train medical students and residents in how to respond to requests that are AI-based that are inappropriate or dangerous, okay? And that's going to be part of the everyday experience of clinical practice. So social technology is just one attempt, my attempt and my colleagues at Harvard, to humanize AI. But all of us are going to have a role in this. And for this, I want to cite two things. One is that in the Chinese tradition, there's a great tradition of a Taoist tradition, which says that the world is filled with negative things, resentment, anger, evil, so many bad things that anything produced by human beings cannot survive. They may outlive you, but not by much. So almost every undertaking we make in this Taoist tradition, the idea is it's going to ultimately fail. Nonetheless, this tradition says, your responsibility is to humanize the world, beginning with self-cultivation, and that for doctors means the cultivation of the humanness of the practitioner, but also by community and societal cultivation. Okay? So that's the issue of humanizing. And I gave you that out of the Chinese tradition. I'll give you another that comes out of our own Western tradition. A great short story to use if you're teaching medical humanities is Henry James's The Middle Years, in his collection of short stories called the Aspern Papers. Henry James wrote a story, The Middle Years, in which a young doctor is taking care of an elderly writer who's dying. And the young doctor has a secret that the elderly writer intuits. The young doctor wants to be a great writer like the writer. And the dying writer tries to convey a wisdom to the young doctor that is about writing, about life, and about medicine. And this is the wisdom, he says. We work in the dark. We do what we can. We give what we have. Our passion is our doubt, and passion is our task. I teach this idea constantly. Look what Henry James says. Our passion is our doubt. That's why we're trained in critical thinking. That's why you go to college. That's why in medical school you're given critical tools of thinking. Why in your residency evidence means something. Our passion is our doubt. But in this, Henry James doesn't say in the final line, and doubt is what we should be doing. No, he says passion is what we should be about. With that doubt, passion. So doubt constrains our passion, but passion should be our way forward. And that passion I take again to be all that human side of us, the emotions that are crucial to our lives, our presence, etc. They have to humanize AI. AI itself brings no value orientation, can be used for any value. Okay? So I can assure you that Google and Microsoft and other major firms are not thinking of the human values of AI. Well, they're thinking of one human value. They have in mind the market and profit, and that's what drives AI right now, the market and profit. Okay? So we're going to have to ask, well, how do we balance that value orientation that's implicit in AI, the use of AI, by technology firms, and will be implicit in the use of AI by our hospitals and clinics? How do we balance that value orientation? How do we provide AI with emotional intelligence? It has no emotional intelligence. I have a next-door neighbor in Cambridge who invented the term emotional intelligence, Howard Gardner. Okay? AI does not have emotional intelligence. How will we supply that for AI? And then, given that AI is going to be coming into it, not just informing, but structuring the patient-doctor relationship, how can the approach I showed you, or other approaches like it, begin to sort of reshape the patient-doctor relationship so, again, that the human issues we've emphasized are there? And I mentioned unintended consequences, and that, ladies and gentlemen, is the end of my talk. Thank you very much.